Thanks, Martine. I'm certainly honored to be here. Although with my appetite, I don't think I've ever been called a nanoseed. Maybe a macro spore, but not a nanoseed. I'm honored to talk today about something dear to my heart, telemedicine. And I kind of walk you through it and give you some examples of what's being done and hopefully what will be done in the future. I'm going to focus today on cardiovascular disease, which encompasses, if you think about it, the entire body, because we have vascular vessels all throughout the entire body. And so this topic is both dear to my heart and hopefully dear to all of your hearts, because you all have vessels. Just remember that. If you look at telemedicine, it really encompasses four primary areas. First, patient access. One problem I have, and one problem throughout the world, is access to medical care. I'm at the University of Alabama in Birmingham. Alabama is a rural state, and I have patients who come from all over the world, quite frankly. My furthest one right now actually flies to see me from Rome twice a year. But I have patients from South America, from all over. Obviously, it's difficult for access in that manner. And indeed, just in Alabama, I have a patient assistance fund just to allow the payment of gasoline for patients to come from all over the Southeast to see us in our specialized clinics at the University of Alabama. Because of that, and because of this access, and over the years I've seen access problems cause significant issues with the ongoing health care, I became interested in this topic over 20 years ago. The good thing about telemedicine is that the patient can be physically remote from a nurse or doctor. But I will say, nothing will replace the patient-physician interaction. Nothing. And these ideas that we can totally do away with that are wrong. Unless we can get a sensor that monitors everything, including the ambience you get from a patient, the discussion with a patient, the one-on-one communication, I don't think it hopefully will ever replace the patient-physician interaction. Telemedicine allows the patient to also be actively engaged in monitoring their own health. We can have a long-distance communication link with some of my implanted devices, which I'll show you in a bit. I actually have a patient up in Alaska who transmits hemodynamic information to me twice a day, and it comes through on my BlackBerry. And I push two buttons and give them specific instructions as to what to do with their medications. Can do it with broadband. Maybe in the future GPS will be incorporated in it, but we can also do it with wireless technology. The monitoring methodology goes from the simple verbal or video questionnaires, simply having a patient answer information, tell us how they're doing. It goes into the non-invasive modalities, such as something as simple as a scale. Again, cost is an issue there. I have a separate fund which purchases scales for patients. Very important if you're monitoring advanced heart failure. And also, we have devices which can be non-invasive and controlled by both the patient and our technicians. For example, one of the examples I used often is the idea of a patient checking their glucose. Unfortunately, for the last year, I've been a diabetic and had to stick my finger to check my glucoses intermittently to assure that my diet-controlled diabetes is still diet-controlled. Well, wouldn't it be wonderful, and actually there are companies working on this, the ability to check the glucose continuously or even intermittently with an implanted device so we don't have to stick our fingers, something I actually hate to do. I'm a wuss when it comes to needles. Implanted devices, patient-operated devices, I'll discuss in just a bit, but very important, the patient interaction and feedback. It can be patient-directed per a patient-specific algorithm, and we are working on such algorithms, but it has to be customized for each patient. Look around the room, look at the guy next to you, the woman next to you, we're all different. And medical care is all different. The idea that every patient should get exactly the same dose of medicine or the same medicine is much too simplistic, and more we're seeing that in how we treat patients. We can do this to talk to the patient verbally. We can do it by video, directed by a health professional, doctor or clinician, and it can be automated again by talking to the patient more specifically. If you look at diagnostics, we have such devices now. Patients who have implanted cardioverted defibrillators, there's one here, placed into a patient. It's, if you will, a life insurance policy. In fact, that's what I tell my patients when we implant one. This is a device that you want to have, but you never want to use, just like a life insurance policy. Indeed, it's there to save your life, should it need to save your life, but hopefully 10 years from now, you'll tell me that, boy, you know, I put this device in and I never used it. I'll say, thank God you never used it. Because you'll know when you do use it. You'll feel it. We can get diagnostic information, for example, atrial fibrillation, the total history per day of a time in atrial fibrillation, which we know now many patients have atrial fibrillation. We would never have known it without this type of software. And the time in atrial fibrillation is directly related to outcomes, both in terms of advanced heart failure, and very importantly, in terms of the risk of stroke. We know that patients who have atrial fibrillation, even for short periods of time, are at increased risk of stroke. So we have such devices today. We're using them routinely in the commercial arena. We do, for another example where I've worked very hard in using implanted devices is in heart failure. We know with heart failure, due to a variety of problems, patients have acute events where they become volume overloaded, they get hospitalized. With each event, there's hemodynamic alterations and progressive myocardial injury. And we know that the more often a patient's admitted, they go into a spiral of worsening clinical status. And indeed, if we can interrupt this spiral, and patients do better in the long run, and we've attempted to do this with a variety of devices to help us monitor a patient's congestion. You know, there's one key element here with heart failure is that congestion that is measured by increased intracardiac end diastolic pressures. So the volume of fluid in the body is associated with worse symptoms and, in the end, worsening survival. So we hope to use these devices to not only control arrhythmias, as the first example I gave you, but to help control congestion. And the idea is that we're only seeing, if you will, the top of the mountain. It's not an iceberg here, it's a beautiful snow-covered mountain. In this case, the mountain's covered with lava. It's a heart failure event. And the symptoms often begin days, sometimes hours before the event. But if we look at what's happening within the patient, what we're doing is we're reacting to that event. We're admitting the patient to the hospital. We're giving them additional toxic drugs. There's only one drug we use in the treatment of heart failure that's not been shown to worsen outcomes. One drug. Most all of them, inotropic drugs, diuretics, they're poisons. Lasix is a great poison. That's how it works. It poisons our kidneys. If you can stay off salt, you don't need as much Lasix, as I tell our patients. Salt is like poison to you. We have to counteract the results of salt by giving you additional poison. We give inotropic drugs. Again, it's a poison. It helps the heart beat stronger, but it worsens survival. So again, we'd like to be able to stop these events so we won't have to use as much poisons, if you will. What happens, and we've shown this in a study I'm about to show you, we've shown that pressure changes begin as early as 6 weeks before such an event. So if we can detect these pressure changes way before even the patient feels anything, we may be able to influence outcomes, and we can become proactive in the therapy. We can do this. We can measure the pressures, we can do a medical intervention, and we can hopefully stave off that heart failure event. We can do this by maybe simple technology. This is data from the TENS. It's a Trans-European Home Monitoring System study. Treated over 500 patients, randomized to usual care. That was just the patient comes in, has an event, and goes home and sees the doctor intermittently in clinic. Versus nurse-directed care, where the nurse is calling and asking how patients are doing, versus a home telemetry monitor, where the blood pressure and the weight is automatically transmitted. And each of these progressively uses also the things before it. So home telemetry will also use nurse-directed therapy. So you add additional levels of support for the patient.